Good morning. My name's James Danger. I'm an embryologist, and I'm producing another video for my third day channel on IVF. This one is on. This is one of a series on oocyte donation, and particularly the obstetric risks associated with oocyte donation. So I've done several videos you'll see on pre-eclampsia in natural cycles and artificial conception cycles. But I thought I would just come back and look at a couple of publications specifically looking at oocyte donation, which have been published in the last year or so. So I've called this Further Risks. So let's just start at the beginning. Oocyte donation, although the pathophysiology of preeclampsia is poorly understood in both natural as well as medically assisted pregnancies, such as oocyte donation, it's suggested that the higher incidence of preeclampsia and oocyte donation is due to the fact that the transferred embryos are completely allergenic to the recipient. That is, the eggs that have come from not the mother, but a different source, and that the mother can detect that the oocyte is different. Previous reviews on oocyte donation have showed that the risk of developing preeclampsia is a threefold higher to pregnancies after IVF with autologous eggs, that's women with their own eggs, after natural conception and non-IVF, natural cycle IVF treatment. So the question, though, is the type of FET cycle may influence the neonatal outcome. So rather than just being strictly an allergenic issue, some argue that it relates more to how the FET cycle has been managed and whether there's a functional corpus luteum in a natural cycle or no corpus luteum in an artificial cycle. And as I demonstrate here, the corpus luteum is the follicle, the ruptured follicle. So here the follicle growing, egg inside it, ovulation, the oocyte's ovulated, and then the ruptured follicle then turns into a corpus luteum, which then produces a huge amount of hormone, which is designed to keep the endometrium or the uterus quiet and allow time for the pregnancy to develop. The corpus luteum, the interesting thing here is corpus luteum only really is effective in the first trimester of pregnancy. And by the second or third trimester, the pregnancy is making its own hormone productions. And theoretically, people argue that the corpus luteum is no longer active. But this data suggests that events that occur very early in pregnancy, the early phase of implantation, may set up the pregnancy for late stage disorders, including preeclampsia. So I've already done a video on the risk of preeclampsia with oocyte donation. This was a review of a paper, meta-analysis and review in 2022, where it demonstrated that the overall prevalence of preeclampsia after oocyte donation was 4 to 5 times higher than after natural cycle and 2 to 3 times higher than after IVF with a woman's own eggs. And they produced this little graph which suggests that eggs are collected and embryos are made using donated oocytes. They're frozen, and then they're normally transferred back into the recipient, either a natural cycle or an artificial cycle. This is one where the follicles are allowed to grow and ovulate. So you produce a natural endometrial lining, natural uterus. Then you just pop the thawed embryo back in at the right stage. And they argue in this case you have far less postpartum hemorrhage and preeclampsia and hypertension, etc. And they're arguing if you use an artificial cycle where instead of there's a follicle growing ovulations like a pill cycle, conception cycle, where the woman is given estrogen and then estrogen progesterone to mimic the cycle, and the embryos pop back in at the appropriate time, and they're arguing this is less safe for mother and child. So there was a paper written in 2024 on egg donation and gestational surrogacy by McCoy, etc. And in that, they're arguing this is an allergenic issue. That's where the pregnancies are different because the egg has come from someone different. The mother can tell that. So the highlights of this is women can carry to term embryos to whom they are genetically unrelated, an evolutionary mismatch. Pregnancy using egg donation or gestational surrogate carries greater risk where the embryo is unrelated to the carrier. Hypertensive disorders and various placental pathologies are more likely in young and healthy carriers of unrelated embryos. And although a lot of people receiving donated oocytes and often surrogacy as well are often young, healthy women. But no, that's not true. The eggs are coming from young and healthy women, but often the recipients are people that have poor ovarian reserve, and they sometimes can be older. So the surrogates and egg donors should be told of the increased risk they face compared to similarly fertile young women. An evolutionary theory can inform future medical research in the field of assisted reproductive biotechnology. But there was a paper published recently in reproduction fertility, but there's been a little bit of pushback. So natural cycle IVF is complicated because you have to monitor the womb from when you ovulate, and that's a very unpredictable thing, as you know. And there's also some disputed when is the correct time to put an embryo back. Whereas artificial conception cycle, everything is clearly documented and organized a long way ahead, and that's a benefit both to the busy clinics and also to the client. So this paper looked at live birth rates after natural compared to artificial FE blasters transfer, and the authors state that concerns have been raised about the absence of corpus luteum, the ruptured follicle, and its hormonal contribution to our artificial conception cycles, which may impact implantation and fetal development, potentially increasing the risk of hypertensive disorders. And remember, these are women who are pregnant who are fit and healthy, right? And therefore you may be putting them under increased risk when they shouldn't otherwise be. These findings suggest that natural cycle FETs may offer physiological advantages, although further research is required. And then the authors go on and say, despite these potential concerns, artificial conception FET cycles remain the preferred approach in its clinical practice due to its logistical advantages. A recent survey of IVF clinics in the United States found that although most clinics offered natural cycle FETs, only a minority actually did them. Nearly every cycle was artificial conception. The reported barriers include unpredictability of ovulation, the need for frequent monitoring, and increased scheduling difficulties. Artificial conception cycles, on the other hand, provide greater flexibility in transfer timing, allowing for adjustments for up to several days. So there was a paper published in August 2025, Are pregnancy complications associated with the conception method in female same-sex couples? So this is a retrospective study. And in this one, the authors asked the question whether pregnancies in female same-sex couples are at higher risk when using reception of oocytes from the partner, what they call ROPA, compared to intrauterine insemination. And a retrospective single-center matched cohort study was performed between 2025 and 23, included 577 case unique female same-sex couple using donor sperm who became pregnant, 88 following ROPA, that's using the partner's oocytes, and 489 following IVF, where the woman is just inseminated with the donor and that she's using her own eggs. And they found that there was no significant difference in hypertensive disorder or pre-eclampsia were observed except for a significantly higher incidence of preterm pre-eclampsia following ROPA. So 0.04, which is significant. So even in this case, there was some suggestion of preterm pre-eclampsia after donated oocyte transfer. So a subgroup analysis showed significantly more preterm pre-eclampsia following ROPA when an artificially prepared frozen embryo transfer was performed. ROPA pregnancies were associated with a higher incidence of preterm birth and first trimester bleeding. There was no statistically significant difference observed regarding neonatal weight, fetal structure malformation, and cesarean section rates. So the conclusion was this study highlights potentially increased obstetric risk after ROPA, especially following artificially prepared FET cycles. These data is crucial to counsel lesbian couples in their decision regarding the method of conception. So if a couple are coming in, they want to use their partner's oocytes, that's fine, no problem. But they should recognise that if the recipient falls pregnant, there may be an associated higher incidence of preeclampsia, and the doctors and obstetricians need to be aware of that and manage it. So there was another study in October 25 looking at how the endometrial preparations impact on the risk of pregnancy. So in this case, preeclampsia is a multifactorial disease, and several factors aside from artificial conception may present a much more high risk of developing the condition. Therefore, a thorough assessment of preeclampsia risk before selecting an FET protocol, optimizing first trimester screening algorithms, and implementing primary prevention methods for truly at-risk patients rather than stigmatizing and abandoning artificial conception should be prioritized. So there was a paper just recently in OBM Online, December 2025, open access one, looking at the incidence of postpartum hemorrhage, which is slightly different to preeclampsia. And this was a systematic review and meta-analysis confirms and provides more robust evidence compared to previous meta-analysis that the risk of postpartum hemorrhage in ovum donation pregnancies when compared to both natural cycle and IVF cycles using women using their own eggs. And they produced this graph demonstrating that the risk of postpartum hemorrhage was significantly higher compared to autologous IVF and compared to natural conceptions. In fact, you can see here for natural cycles, it's about 5%. For autologous IVF ones, it's about 7% and up to 18% higher with ovum donation cycles. Now, these aren't equivalent because the ovum donation cycle is nearly always an FET, a frozen FET cycle. But it's only because it's difficult to put the embryos back in fresh cycles. So the authors go back and say, they make the point that oocyte donation pregnancies are characterized by high levels of immunogenetic mismatching due to inheritance of both paternal and donor-derived genes. So they're actually taking the view that oocyte donation has got an allogenic component to it. And then they go on to say, as postpartum hemorrhage is a leading cause of maternal death, should be underlined. Its prevention and treatment is crucial to achieve the United States Sustainable Development Goals relating to decreased maternal mortality worldwide. Additionally, it's still uncertain whether the increased risk of postpartum hemorrhage in oocyte donation pregnancies is correlated to the increased risk of pre-eclampsia in women. Basically, women in pre-eclampsia have a 1.5-fold increased risk of postpartum hemorrhage. Then there was another paper just recently where they looked at the type of endometrial preparation comparing, and this one here they investigate the impact of natural cycle and modified natural cycle compared to artificial cycles and the internal outcome. They concluded that the natural modified cycle should be promoted as a preferred approach for endometrial preparation in oocyte donation pregnancies, at least when regular or inducible ovulatory cycles are present. So this is the results. Once again, there's data after data after data, but they're all different. The results, they report a lower incidence of both hypertensive disorders of pregnancy, 7 against 18%, including pre-eclampsia and placenta previa, in modified natural cycles compared to artificial cycles. So this was January 2016. That is only about 5 or 6 days ago. So this is almost hot off the press. Furthermore, better neonatal outcomes, at least in terms of low birth weight and intensive care admissions, were observed. From a molecular point of view, a significant gene overexpression and pro-angiogenic placental growth factor and vascular endometrial growth factors were obtained in natural cycles. Conversely, anti-angiogenic soluble forms like tyrosine kinase 1 were increased in artificial cycles, placenta, compared to natural and modified. Now, I need to go back and do a separate video on this. So there's a paper in 2019. So I've just gone back a little bit. I'm doing this for a reason. So the incidence of hypertensive disorders following sperm donation in IVF, an Australian statewide representative cohort. Does IVF using donor sperm increase the risk of hypertensive disorders in pregnancies and fetal growth? And the answer is IVF conceptions arising from sperm donation are not associated with the increased risk of hypertensive disorder of pregnancy or fetal growth retardation. And the data is a complex set of data, but I've picked out, I cherry-picked, you could say, maybe I'm a bit naughty, but I've cherry-picked a table looking at comparing donor sperm to donor eggs and donor eggs in terms of the risk of hypertensive disorders and preeclampsia. And you can see here that there is no risk, odds ratio of 0.9 to 1.4 for donor sperm, but clearly a risk for donor oocyte, and no different, as very similar risk for donor embryos. In other words, it's not the sperm, it's the oocyte that appears to be different. So, after adjusting for covariates, maternal age, BMI, and ICSI, etc., no difference remained in the risk of hypertensive disorders pregnancy between donor sperm and the partner sperm conceived IVF. Consistent with previous findings, this is in 2019. This goes back a long way. This is 6 years ago, right? I mean, this is a series that has been around for so long. Consistent with previous findings, an almost 2.5-fold increased risk of preeclampsia was found for pregnancy conceived with using donor oocytes, and there was no further increase in the risk of hypertensive disorders among donor embryo pregnancies greater than that attributable to the use of donor oocytes. So it's the oocyte, it's not the sperm. And this is a similar sort of data. This is for hypertension, or this pre-eclampsia. Included in this including parity with multivariate models among this cohort resulted in comparable findings to the overall cohort. There were no associations between hypertensive disorders and sperm donation, but there was an increased risk among donor oocytes and donor embryos. This was in 2019. So what about donor sperm? So the authors concluded that their epidemiological studies suggest that sperm donation in IVF in the absence of seminal fluid is not likely to be associated with an increased risk of hypertensive disorders of pregnancy or fetal growth retardation compared to IVF with donor sperm. The mechanism by which the increased risk associated with seminal exposure is conferred remains unclear and warrants further investigation, and I think that's a different issue. In contrast, there is a strong association between oocyte donation and both hypertensive disorders of pregnancies and fetal growth retardation. Pregnancies conceived via oocyte donation should be watched closely for the development of these symptoms. This was in 2019. So, once again, this is another one. Perinatal outcome of children born after fresh or frozen embryo transfers using donated oocytes. So this was in 2022 in human reproduction. The question was, do children born after vitrified thawed oocyte embryo transfers using donated oocytes have worse perinatal outcomes compared to fresh? And the answer is, there was no significant difference in the birth weights and prematurity rates between fresh and frozen embryo transfers in newborns after oocyte donation was found. Once again, the similar sort of information here between artificial and natural cycles. And once again, the gestational hypertensive disorders are significantly different, as are Caesars. But they also found a significant difference in the rates of hypertensive disorders in natural cycles compared to artificial cycles, although only borderline significance following co-founders. So they do the co-founders, and often the difference becomes far less. So, final comments. Oocyte donation is an assisted reproductive technique that enables women with diminished ovarian function or reserve to conceive. And often women are older and the oocyte donors are younger. Various studies on obstetric outcomes report a higher incidence of pregnancy complications when comparing oocyte donation pregnancies with naturally conceived or autologous oocyte in vitro fertilization and autologous ICSI associated pregnancy. The jury is still out whether these increased risks are due entirely to the allergenic origin of the oocyte or due to the widespread use of artificial conception cycles. Regardless, postpartum hemorrhage and preeclampsia are leading causes of morbidity and death, and clients need to be counselled about the current observations. This is not medical advice, just common sense, given the growing number of publications reporting the rise. Actually, what I find disturbing is that in 2026, and I'm an embryologist, I've been doing IVF since I started my PhD in 1977. I've been doing IVF since 82. It's interesting that in 2027, we do not understand the relationship between the functions of the corpus luteum and the outcome of pregnancy. If future studies fail to find that a corpus luteum is essential, then artificial cycles will remain the primary regime in which to transfer frozen embryos. And then the issue, right? This area then will be forgotten and related only to donated oocyte cycles, and the cause will be related to the allergenic source of the oocytes. This in itself is fascinating because it tells us something that's important in the origin of the oocyte and implantation. If future studies do find that a corpus luteum is essential, then focus will move to examination of the client's risk for preeclampsia, and artificial cycles may not remain the primary regimen in which to transfer frozen oocytes. I think that's enough for this video. I'll just go back and thank you for listening. My name is James Danger. I'm an embryologist with more than 50 years experience. I'm not a medical person. This information is not medical advice, but hopefully it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice you receive. Press subscribe. You may like to fund me with my GoFund page, leave a comment and select like. And just one little plug right at the very end for my other activity, which is an online EQA program and a training program in andrology and embryology at fertaid.com. So I'd just like to finish. Thank you for your time. If you persevered, I understand IVF is a very personal journey that involves the action of many different techniques, issues, and staff. It helps to understand all aspects of that journey. I hope this information may be of value. If you like it, please subscribe and tell other of your friends about this service. And at this point in time, I would like to say thank you and good night.